we're going to talk about how did we define the problem, how did we meet Sandeep, where the budget came from, barriers and boons to success, and learning points that I think we've learned and perhaps Sandeep will recognize, and we'll just take it through that. So it's interesting, children's services lag far behind adult services, both culturally and clinically, in terms of preoperative assessment. And the reason why hospitals don't have these services is because the NHS refused to fund them. And we've made lots of arguments over the last 10 years about parity of esteem and that children can really benefit from preoperative assessment. And that's now recognised in the NHS. And that's why the NHS surgery priorities stipulate that pre-assessment is required for all people having elective surgery, including children and young people. And so this sort of service allows hospitals to catch up where they may not have the infrastructure to take that on. Our problem and why our needs sort of chimed with Sandeep's product about 18 months ago was that following COVID, we have a pre-assessment service. We have about 15 nurses in it. It's quite robust. We're quite advanced in the process. It's well funded. We see about 14,000 people a year. We don't manage to see everybody because of resource challenges. We see between 70 and 80% of people. And we used to triage patients immediately after they would see their consultant surgeons and be given a surgery. And then we would triage them into needing to see a consultant anaesthetist, a dual clinic with a nurse and a consultant anaesthetist, a nurse on their own but face-to-face, so perhaps they might need some investigations and blood tests, or a more remote consultation, such as a telephone. And then as COVID came about, that remote conversation became virtual. And following COVID, that patient pathway completely dissolved. It was all remote. The way the patients saw their surgeons was remote, and they were listed just on a spreadsheet. And so our service didn't have a touch point as patients were listed in order to assess their fitness for surgery and their risks. Our hospital is very paper-based. It's going through a digital transformation, so it was very difficult to assess a patient's needs just by seeing that they had a tonsillectomy. They could have a tonsillectomy and be fit and well otherwise, or they could have major heart complications or respiratory complications. Very hard to guess. And so we weren't using our resources adequately. And so Sandeep's service that would digitally help to triage and put patients in risk buckets for us was really our key need, especially in the recovery period following COVID, as our patient numbers expanded rapidly, and we were finding patients in the wrong clinics, in the wrong settings, and it was frustrating. So that's where we sort of chimed, and his service was there, and it's developed, I think, in partnership as we've gone on. We've worked really closely together over 18 months, and so the technology platform was there, but how that was implemented in a patient real environment wasn't there. And there was a process of so the barrier to implementation, we couldn't just set it up and press go in our hospital. We needed to learn how to categorize patients digitally, and that process took about 3, maybe 6 months to get it really refined. And so that the algorithms that we were using, the patient questions that we were using, were putting people in the correct buckets, and we were testing that regularly. We'd have a senior nurse who was looking at how the patients were categorized based on the algorithms, and we'd have regular meetings. We're having weekly meetings with the REMCARE team to look at questions, look at language, to understand what that meant, how patients or parents were interpreting certain questions, And it took us about 6 months to really nail that and get people into the correct buckets. It was a collaboration. It was very easy to start for us because the West Midlands Health Network supported this project. So we didn't have to go through a business case. They supported it directly with REMCARE, which allowed us to start the whole process quickly. It minimized risk, I suppose, for REMCARE because they're getting paid to help develop their product, but also it minimized risk for us because we felt there was some advantage in improving our abilities to see patients, but we weren't having to spend any money on it. We were having to spend time, and so that's where we got. And that brings me to a learning point. Actually, I think we'd have done better, Sandeep, if we'd have allocated some time or money to help from a clinical point of view. So you had time and resources allocated to REMCARE and the development of it, and that was very good. But within our clinical team in the hospital, we had no time. And so we were trying to respond to Sandeep's team's questions, and sometimes we weren't very timely about it, and we could have sped up that process because we were just clinically stuck. It was a very collaborative process. The sort of building blocks of the product were there, but we learnt about the product as we went along, but I think Sandeep learned from us about how we managed our clinical pathways, and his team helped us understand our pathway better because we worked together, understanding the pathway, and when we adapted or learnt a new solution to the algorithm, new ideas presented themselves. So we were originally focused on clinical risk stratification, but actually through discussions and working together, we realized actually there are we've got a clinical risk strategy which is designed in the product, but also it's not new technology for Sandeep, but we've also got a stratification of needs, such as health inequality needs that Sandeep mentioned, that we could layer in and support our products, support our patients going through the service. An example will be identifying anxiety. You could be really ill or very fit, but anxiety is a separate pathway that we've layered into our systems, that we can refer those groups to different resources, learning disabilities, anxiety, or play therapy. Or have a detailed conversation with the nurses, but other health inequalities such as can the patients even get to the hospital? And there was a separate charities budget in our hospital that would pay for parents to bring their children to the hospital, but they weren't able to identify those parents in need. But with this system, we could optimize other supports within the hospital within that patient pathway. So I think that was key. We were initially skeptical, and I'd read lots of articles about apps and stuff, and in Ireland a similar product with an app that required downloading never got off the ground despite huge amounts of investment by the Irish government. And I was personally skeptical that a parent would have to, if they had to download an app, would even engage. But that's been proven to be wrong, and they do engage. And I think they engage because they understand there's a real connection between, it's a very patient-focused activity, and if you were shown our algorithm, you'd be surprised. It can be over 100 questions that parents have to answer if they have a whole plethora of illnesses with their child. But they certainly, most of them complete it in 5 or 6 minutes, but they could spend 15-20 minutes on the app answering questions, which is a lot of time and a lot of detail. But when we've asked them how they look at the app, they feel more confidence in that we're taking their problems much more seriously, and they will engage with it. And we've got a sort of 60 to 70% usage where parents will complete the questionnaire. We have a full picture of their clinical details. And the messaging, as long as the messaging is correct, and we worked on the messaging a lot, how they receive that message from the hospital, how it's important to them, is a really important learning point. Timing is important. So the timing was right for us. We were seeking this product. The time was right because of NHS requirements were pushing us to have to do this, and timing is right because Sandeep and his team were developing this product. So timing is really, really important. Working within the hospital, it's interesting because there's a core team that are involved in it and bringing it out into the clinics and getting the nurses to use it. And there is a lot of resistance on the ground about using new digital products. Doesn't matter how simple it is, it's just another thing to open, another thing to use, and people really don't like it. And that was a barrier for us to use widely. And the only way around that actually was sitting with, so you had some nurses who were used to it, who'd been in on the development meetings, and myself, and the only way really to get other nurses to use it was to sit with them in a clinic, look at the REMCARE results, and then read it through with them, and they go, oh, I know everything about this child before I've even. So it speeds up their appreciation of what child they're going to see. It speeds up their clinic appointment, and then they receive that benefit. But they only get that with confidence of sitting with them for 1 or 2 clinics, and then they sort of use it on their own. And I think that's an important thing. We've gained confidence in the way we use the product over the time. So this idea of it being funded by the ODN allowed us to gain confidence and work differently. And that has allowed us to actively change some of our pathways so we see patients differently because of the product. That's where some of the savings come in, and the savings come in mainly in I think there's marginal gains in theatre utilization, and I think there is a degree of error there, but the huge savings is in nursing time, and that's very costly. And we've gone to equivalent hospitals where they're using about 2 or 3 whole-time equivalent nurses to triage and manage patient pathways, whereas essentially we have a senior nurse who manages the REMCARE platform, and it saves a lot of nursing time in our clinics and allows us to see more patients in more clinics. That's what we've learned from it. So I don't know, I hope I've covered a wide range of stuff, and if there's any particular questions anyone wants to ask, go for it. Oh, integration. I just want to mention integration. It was a standalone product, a standalone development cycle. And I think that helped us because we could just get going. There's no barriers to integration. But later down the line, we did some workarounds around some integration, so we could upload lots of patients very quickly, and that helped us to roll it out in our service. But now our challenge is to get the hospital to integrate it into the rest of its digital service. So we know the benefit of it, and that is the challenge for us to convince the hospital, but also Sandeep to do it. But I think probably the product's in a different place, so you could probably go to a hospital now and say, well, actually, you know, there's a lot, you've gained a lot of evidence from our site. You've got lots of data. You presented that on this previous slide, so it's a much easier process, I'd imagine, going to another institution.